The topic is cranial nerve nuclei. Of course, they are in the brainstem. So cranial nerves of the brainstem, specifically from number 3 through 12. And we have a series of objectives as far as splitting them into various categories. So we can see those. And then we'll go regionally. We'll start in the medulla, and eventually we'll go into midbrain in that order. Now, this is a practically and clinically very useful kind of ordering and presentation. You can do it other ways. You could do it functionally. I'll make a comment on that right here. So when you look at the listing of cranial nerves, what I expect that you would be very familiar with the innervation territories and what they do. And a lot of this would be coming from your study of anatomy. So especially cranial nerves 3 through 12, so we're excluding olfactory and optic. They're true peripheral nerves, 3 through 12, and they will be presenting in all of these areas. Now, one could go in a numerical order, right? You don't have to. For example, we could highlight these 3, oculomotor, number 3, trochlear, number 4, and 6, or abducens, as the cranial nerves that move the eye. And in fact, there is a system also for cooperation and collaboration between these nerves, right? But then again, numerically, we do have number 5, trigeminal, that just popped in. And this list will give you kind of what you need to know about peripheral distribution of fibers, be it sensory, motor, or both, meaning mixed. So in the case of those mixed nerves, potentially having categories of fibers in all categories that you can think of. And there will be several of those that we can think of, and I'll make sure to point that out, okay, in case there's any kind of doubt about those. All right, so number-wise, again, facial, see what it does. Vestibulocochlear, see what it does, purely sensory. Glossopharyngeal, one of those really complex ones. Vagus, very similarly, and even more so, very extensive peripheral distribution. Accessory nerve is unique, obviously. So we're going to find those motor neurons in spinal cord, and yet it presents as one of our cranial nerves. So it's rather unique. And then finally, hypoglossal, which is motor to most tongue muscles. And the genioglossus muscle function will be the most important one to stick the tongue out, that you also test clinically, okay? So with that, of course, this should ring a bell as far as cranial root attachments, cranial nerve root attachments to the brain. And we are excluding olfactory and optic, and you probably recall that the actual olfactory nerve is called the phyla olfactoria, really traversing the cribriform plate, so they wouldn't even be here in a strict sense, right? And of course, optic too is attached to forebrain, and it is really a tract of the central nervous system. But then oculomotor, and behind you see all of these attachments. And all of these attachments should be visible and identifiable in the laboratory, right? We'll do some of that, keeping in mind that depending on the kind of brainstem that we happen to have at the tanks where you're working, some of them may be deficient in terms of they may have been ripped or missing or something like that, but you can certainly put it together, okay? From atlases and also maybe from several cadaveric examples you can put it together. So, which is also to say that by way of reminding everybody, the way these nerves exit the cranium, because by convention, regardless of whether the fibers are actually coming or going, so naturally your sensory ones, information-wise, would be coming in, but by convention, all of these fissures and foramina are called exits for those specific cranial nerves, and sometimes divisions, right? The 3 divisions of trigeminal would come to mind. So nevertheless, this is something that we don't work with here in neuroscience, but of course it's part of the knowledge base. All right, so with that, let's delve into the meat of the material and identify the types of fibers carried by cranial nerves, keeping in mind that the so-called special category only exists in cranial nerves, all right? And this is for specialized functions associated with the head, because then you might recall the general somatic afferent efferent, so sensory and motor, and so-called general visceral, aka autonomic, of which we have, of course, sympathetic, parasympathetic. Spinal nerves have them, right? The spinal nerves won't have any of the so-called special ones, right? And cranial nerves potentially may have representation of all of these categories, okay? So we may have to trace them, all right? And with that, of course, I highlighted spinal cord for us, and these are embryologic. So early in development, when the alar and basal plates are separating, of course, being separated by sulcus limitans, this longitudinal groove, right? Okay, by which we can determine which is sensory and which is motor. In the spinal cord, we only have the so-called general. Even in terms of the visceral motor, future sympathetic, and if you're down in those sacrosegments, some of them will have parasympathetic, right? So that describes our spinal cord. And there is a dorsal-ventral split, dorsal-ventral distribution, segregation of sensory versus motor, right? So now we are in lower brainstem, hindbrain, embryologically, and they are just developing. And what is really happening here is that this configuration is being stretched, so to speak, laterally. And of course, the location of ventricular system changes as well. And we see that typical floor of the fourth ventricle. This would correspond to our rhomboid fossa, right? So having said that, now your sulcus limitans, that longitudinal groove, really is separating medial from lateral. So in the hindbrain, and this will describe medulla and pons, and we'll only find 2 motor cell groups in midbrain, so it's relatively easy to conceptualize. So let's talk about lower brainstem again. In the hindbrain, we're going to see these motor cell groups medial to sulcus limitans. And whatever I'm expecting to be sensory will be lateral to sulcus limitans. There is one little bit of caveat, okay, which is to say that there is a so-called special visceral efferent, SVE, and don't look at me for using those categories. I really dislike acronyms, abbreviations, and things like that. I like something that is really a description based on meaning, okay? So Nolte does this, and other very skillful and smart authors, they call this branchial motor, because we talked about this earlier, and this cell group actually occupies an intermediate position where I'm hovering with my little dot, and eventually during development those cell groups actually sink a little deeper, a little more ventrally into the tegmentum, the branchial ones. Well, these are the ones that will go to musculature derived from those pharyngeal, also known as branchial arches, that of course turn into gills in fish, and these various structures in us, right? So derivatives of the pharyngeal or branchial arches. So many authors would call these branchiomeric nerves or branchial component, and more than likely that's how I'm going to refer to it. So for example, nucleus ambiguus would come to mind for vagus and glossopharyngeal. And then like facial nucleus would come to mind. And of course, our primary motor trigeminal nucleus comes to mind. Okay? So they are the so-called branchiomeric nerves. They'll go to these derivatives of those branchial arches. So don't be surprised to see them. And once again, they are in sort of an intermediate position, and eventually they will sink a little deeper, about here, into that tegmentum. Now this will help you immensely whether you are in medulla looking for a nucleus ambiguus, for the vagus for the most part, a little bit, tiny bit of glossopharyngeal component, or you may be in the pons looking for a facial motor nucleus, or a little bit higher in the pons looking for that principal motor nucleus of our trigeminal nerve. So that will help you a great deal. All right? Now keeping in mind that the somatic motor column is always medial-most. And when we get to the next slide, we will have a longitudinal view. And once again, think about this type of segmentation going from lower levels to higher levels. And of course, we'll be climbing those rungs of the ladder, so to speak, from groups of cranial nerves to another group of cranial nerves, and then more rostral ones, until you eventually run out of them, right? When you hit that oculomotor nuclear complex in midbrain. Very good. So as far as organizing principles, the somatic motor column is always medial-most, starting with my hypoglossal. And then you go from region to region and identify them. That's your somatic motor. or so-called somatic efferent, okay? I will say motor. All right, let's be very clear, very specific. And then your visceral efferent, that's your preganglionic set of neurons for the cranial division of our parasympathetics. And as you've heard before many, many times, some of our cranial nerves do have that component. So 9, 10, 7, and 3 come to mind. Okay? Having visceral motor component. That is relatively closest, still medial, but closest to sulcus limitans, that longitudinal groove. That longitudinal groove that we have actually observed a little bit on the floor of that rhomboid fossa, the floor of that fourth ventricle. And we will be looking for it when you're actually holding the laboratory specimen in your hands. Excellent. And I already mentioned the branchial motor has an intermediate position, but because this is so early in development, eventually we'll find those a little deeper in the tegmentum, those branchial motor ones. Don't be surprised and don't be alarmed by that. Excellent. Now, talking about afferent sensory components. Well, we already agreed that they will be, as a general rule, lateral to sulcus limitans, if you can see a sulcus limitans. All right? Even if I can't, if I'm within a section and I'm orienting myself, those will be laterally placed. And there will be a somatic sensory category. There will be a visceral sensory, aka that general. I will never ever say general. If I want to mean visceral sensory, you will hear it that way. And I think from our point of view, a preclinical point of view, best is to define what these fibers do and go with that. Okay? Some people revel in acronyms and they're rattling off their wonderful knowledge. I'm not one of them, okay? But if you really wanted to gain insight, then you're going to say, well, that visceral sensory component, really the main one is going to be a nucleus of the solitary tract in the medulla. And it goes a little bit into the pons, kind of inconspicuously, but what we're concerned about the most will be in the medulla, and I will point it out, okay, when we discuss vagus and glossopharyngeal. So there will be no doubt whatsoever. So we're going to have, especially that cardiovascular zone, the more medial zone of nucleus of solitary tract. And then you're going to have the so-called special sensory, hearing, vestibular, and they are lateral most, typically, when you're looking at hearing and vestibular. And taste is unique a little bit. It will join nucleus of solitary tract, but again, rhyming with this theme, it will be a little more lateral in localization. And I will never, ever ask you to point to the taste recipient zone of nucleus of solitary tract. Cardio, respiratory, more likely, but not the taste. But in theory, we need to know where those fibers go. And we just call them taste fibers. And several of our nerves will have those taste fibers, okay? And some of them you already learned in anatomy. Awesome. So we are expecting sensory stuff lateral in localization. There will be a very unique kind of organization when it comes to the fifth cranial nerve, trigeminal. And I warned you last time we were here regarding the pons, and a little bit about medulla, that this is coming up, and I will show that fully for trigeminal. So the trigeminal sensory system will have its own uniqueness, long story short, and this is what you need to watch for. The splitting, anatomically and functionally, according to modalities. So there will be a cell column associated with pain and thermal. There will be a group of neurons, the principal sensory nucleus of trigeminal, associated with vibratory sense and fine touch, and that very unique mesencephalic nucleus associated with proprioceptive input from muscles and mastication. Okay? So the trigeminal will be integrated into this, but we will have to tackle it in its own right. So once again, I'm just giving the disclaimer early on so that we go with the flow. And with that, what we are seeing here, really, and so many textbooks have this, is a dorsal view of the brainstem longitudinally. Only one side is shown, and it's flattened out, as it were. In real life, it looks like this, and we're really just focusing on one side, right? So everybody can see that. I pick up the midline over here. And then, of course, if I'm seeing my nice sulcus limitans, I can conceptualize all of my motor ones that I'm tracing, derivatives of the basal plate, motor nuclei, and then derivatives of the alar plate, in this case, lateral to sulcus limitans and their intricacies. So nevertheless, we'll be going from caudal to rostral in that fashion, okay? So once again, I'm drawing your attention here, the sulcus limitans running longitudinally on the floor of the fourth ventricle, like this. So we'll have motor groups of nuclei that are discontinuous in nature. So what it means that three-dimensionally, these are like little sausages. I call them sausages, those linked sausages. And it has an extent. It has an extent. And of course, in cross-section, you will be getting representations of that, starting with our hypoglossal, and it will taper off. This is very much like, generally speaking, segmentation. Think of segmentation. And embryologically, I'm probably said this before, these are called rhombomeres, or rhombencephalon, right? Rhombomeres would be the embryologic, and even in terms of gene expression, certain patterns associated with it. So there is a type of segmentation. It doesn't just happen, all right? And let's just leave it at that. We don't have to delve deeper. So the idea being is that you're leaving the territory of one particular nerve, for example, here in the somatic motor column, and then there is an interruption seemingly, and then you're entering the territory of another one, and in this case, of course, it's going to be our abducens nerve, right, with its nucleus in lower pons. And then for the somatic motor column, there is going to be a great interruption until you hit these trochlear and oculomotor ones up here in the midbrain, right? And that, of course, reminds us some other concepts, such as first of all, why we need medial longitudinal fasciculus to coordinate all of these actions, right? So that will make a lot of sense too. And then similarly, your visceral motor column is also discontinuous in that sense that you'll find the dorsal motor nucleus of the vagus, and it will taper off, and there will be a very small component that belongs to glossopharyngeal, or the inferior salivatory nucleus. And then again, kind of a small one, the superior salivatory nucleus, and then that will go out with the facial nerve to go to those, the lacrimal gland, innervational lacrimal gland, and those glands on the palate and that sort of thing, right? And then again, a huge interruption until you get the final one of our autonomic or visceral motor or parasympathetic, and let's just call it what it is, that parasympathetic motor that is associated with the oculomotor complex, and we'll call that Edinger-Westphal in the midbrain. That's going to be the final one of the visceral motor column. So you see the way it's mapped out, just like that. And of course, we're going to have these branchiomeric nerves, or the branchiomotor component, that also sinks deeper, that you cannot appreciate from this dorsal view, but we'll see in the actual brain section. It will be more in the center of our tegmentum when you look for a nucleus ambiguus, or you look for the facial motor nucleus, or the trigeminal motor nucleus, those branchiomotor nuclei. And that's that for the motor ones, right? And there are going to be sensory columns of neurons, a somatosensory column. A lot of that will have to do with the trigeminal nerve. That's your somatosensory column with its uniqueness, a viscerosensory column. And for the most part, that's the nucleus of solitary tract. And a so-called special afferent. And for my purposes, really, because I dislike the special whatever terminology, rather let's just name the modality. If you mean taste, then say taste, and tell me where the taste fibers go. Okay, that's the taste recipient zone of nucleus of solitary tract, a little bit laterally located. And then the really big one is the ones, okay, that are associated with cranial nerve 8, vestibulocochlear. So there's going to be a vestibular and a cochlear division, and both of those are lateral, and they are lateral most. I made that point when we were poking in the medulla. So all of those, so look for those cochlear nuclei, look at that, and look at the vestibular nuclei. The vestibular area is rather large. It's large enough that gross anatomically, I was able to point to it. If you care to watch my video, and Nolte shows it in his atlas, and everybody shows it in their atlases, vestibular area, okay? So this is how we map it out. And these are, in fact, derivatives of the basal plate for the motor. So we're gonna take the sensory ones out. This is from Siegel and Sapro, our regular textbook. Okay, so we're only identifying the motor ones, very nicely put together, look. So whether you're looking at these concentrations in the medulla, and of course there will be cranial nerves going out, you get the idea? That's the quote segmentation. And there will be ones in the pons and going out with those nerves, and there will be ones located in the midbrain, going out with those nerves, right? And of course, this very unique one, the spinal accessory nucleus, giving rise to the accessory nerve. Awesome. So, as I said before, most medial is the somatic motor column. And then your parasympathetic motor column, okay? All of these. And then lateral most and ventral is the branchiomotor group. All right. A very important concept when you talk about motor cranial nerves. And this is clinically critical. It's called supranuclear control. Supranuclear control of motor cranial nerves, right? Because they are, in fact, lower motor neurons for those functions. So just like for the rest of the body, but it's mediated via spinal cord, where you find the alpha motor neurons, lower motor neurons in the ventral horn. We have the equivalent of these, but they would have to be divided among all of those cranial nerve nuclei, and there are a couple of representations here from this textbook. Happens to be from Haynes, but it doesn't matter, kind of hinting at the oculomotor and nuclear complex, maybe an abducens and that sort of thing. But the bottom line is they're motor, and there are supranuclear influences. That's the terminology you use. So the upper motor neuron will be in cortex, so particularly for the ones that are under voluntary control. And there are so many examples and clinical examples that you will be using. When you examine a patient, you're going to ask them, okay, wrinkle your forehead, or show me your teeth, or smile. Okay, we just tested facial, and stick your tongue out. You just tested hypoglossal, and voluntarily driven from regions of the cortex, right? So that descending input, output from perspective of cortex, input from perspective of those nuclei. Of course, part of the cortical bulbar tract, right? You may want to think about that. But the big concept is supranuclear control, because then you're going to be asking a question: if there's a lesion, is there a supranuclear or nuclear or infranuclear lesion? A nuclear or infranuclear or peripheral lesion will look the same because they are lower motor neuron lesions, and supranuclear lesions will look more like upper motor neuron lesions. Okay, so it may sound tricky, and injecting new phrases and new concepts into this, but there is something to be gained from all of this. Supranuclear control, particularly the ones that are voluntarily driven. Eye movements included in this, but for eye movements there is an entire system that is coordinated from cortex through certain areas, specialized areas of the pons, and other areas of brainstem that we'll talk about separately. All right? All of these. Just understand this big central nervous system, right? Supranuclear is really the equivalent of upper motor neurons. You're hitting lower motor neurons, and then you go to that peripheral target, whatever the target may be. Now, very importantly, we're going to have sensory components, the adult derivatives of the alar plate. And I just have a list from caudal to rostral. So your solitary tract and nucleus. Solitary tract is the white matter carrying those influences, and it's going to terminate in the nucleus. Okay? That's going to be see where it is, lower medulla, and it will go into the open part of the medulla too. You would recognize this as the obex, right? That lowermost point of our rhomboid fossa. Here's a rhomboid fossa. All right, so you see where we are. Okay, the various vestibular nuclei and cochlear nuclei, I have to draw this in. Siegen and Sapru, to my great surprise, forgot it, okay? But that lateral portion of upper medulla, and some of them will go into the pons, okay? And they are going to have the sensory nuclei, really making up the trigeminal sensory system. The spinal trigeminal nucleus, this really long column, that is the equivalent of substantia gelatinosa of the spinal cord. So the equivalent function for the trigeminal system dealing with nociception and thermal information is in this long column. And then your main sensory nucleus, mid-pons, is the one that deals with vibratory sense and fine touch. And the very unique mesencephalic nucleus, which begins in the pons and ends in midbrain, deals with proprioception from muscles of mastication, okay? So we'll come back to this. Spinal trigeminal nucleus, a main or principal sensory nucleus of trigeminal, and the mesencephalic nucleus of trigeminal. Awesome. So at this point, because there are just so many ways of covering cranial nerves, again, as I said before, you could go by number up or down, supposing your knowledge is advanced enough that you can crisscross. Or you can group them by functional categories. That's very, very legitimate. I think that's, again, a little bit higher order. And yes, we are supposed to do that eventually. But, again, clinically very, very useful, and functionally very, very useful, and looking at lesions, that type of thing. A very useful categorization of looking at cranial nerves as cranial nerves of medulla oblongata. So the ones that are attached to medulla oblongata, and then the ones that are attached to pontomedullary junction, that one big old cranial nerve of the pons, trigeminal, and then the two remaining nerves of the midbrain are attached to midbrain. And we will go in that order. So we'll tackle cranial nerves of medulla oblongata in this order. So you see exactly how they are attached. So you see that olive, and then of course attached to the preolivary sulcus is the various rootlets of cranial nerve 12, and then to the post-olivary sulcus you see 10 and 9. Accessory joins them, so it ascends, and then it joins vagus and glossopharyngeal to get out of the skull through the jugular foramen. Okay, very good. So looking at hypoglossal, that we have already agreed is one of our somatic motor nerves. And I expect the nucleus to be very close to midline, medial most, right? And we're poking in the medulla, and sure enough, the hypoglossal trigone, that little bit of elevation that you see, actually is formed by the underlying nucleus, and it's here. And if you trace the nerve, sure enough, this would be sort of my histologic representation of the hypoglossal nerve root being attached to that pre-olivary sulcus, because I am seeing that olive, the inferior olive, and it's medial to that, and the nerve is coming out. And of course, when you see these other nerves, vagus and glossopharyngeal, they will be above and dorsolateral to that olive. So that's a very good hint too. But we're still looking at hypoglossal. So once again, it's closest to the midline. It comes down like this. And there will be a vascular territory associated with this, sort of like this, and another one that we'll address at the end of the course. And there we're going to be talking about lesion signs and that sort of business. But keeping in mind that most of the supranuclear control to hypoglossal nucleus is coming from the contralateral side. So what it is peripherally is that from this nucleus, right, we get the innervation to genioglossus muscle. So genioglossus muscle on each side causes the tongue to protrude. So what ends up happening, if there is weakness from this nucleus and distal to it, okay, nuclear or infranuclear or peripheral damage, the tongue deviates toward the lesion side because the normal side pushes it over, overpowers it, pushes it over. Now the supranuclear lesion, if there's a cut here, it's going to be the opposite sign clinically because the drive is coming from the opposite hemisphere. So the tongue deviates to the side contralateral to the lesion. But of course, I'm looking for a lesion most likely in the hemisphere somewhere. Okay, so contralateral to that side. And that is why it actually does make a difference, you know, when you look at what is supranuclear, what is nuclear damage. Accessory nerve is next, number 11. Very unique nerve because the motor neurons are in the spinal cord, the uppermost several segments of the spinal cord. So these are the motor neurons. Yes, we are getting supranuclear control. A lot of it is contralateral, maybe not entirely, but a lot of it. I really don't put a whole lot of emphasis on categorizing this nerve because there is controversy about the embryology of it. You would consider it somatic or branchial. It really does not matter in a practical sense. So importantly, the nerve root ascends and it goes through foramen magnum and joins vagus and glossopharyngeal to get out of the skull through the jugular foramen. So sometimes there are combined lesions at the base of the neck or maybe near the jugular foramen. You might even see a combination of lesion signs. But the bottom line is the clinical testing is sternocleidomastoid and trapezius functions. Shrug your shoulder and turn your head. And remember, the turning of the head is because of the activation of the contralateral sternocleidomastoid, just to orient yourselves a little bit again. Okay, very good. So we did hypoglossal, we did accessory. Vagus, number 10, is next. So the vagus, as a summary, originates from motor and sensory nuclei of the caudal and mid-level medulla. So we could look at a slab of medulla, various levels, to get to the nuclei of the vagus nerve. So nuclei and regions of interest are marked with the letter X's. Okay? Now gross anatomically, a vagal trigone marks the location of the dorsal motor nucleus of vagus. Okay, that's going to be up here. So just above your hypoglossal nucleus. So your hypoglossal nucleus nerve comes out like that. I expect kind of a slender, more elongated dorsal motor nucleus of vagus. And then your nucleus of solitary tract. This is the solitary tract itself. Needless to say, this is sort of a mid-level medulla, myelin stained. So dark areas have myelinated fibers. You're recognizing medullary pyramid. You're also recognizing, I trust, the inferior olive or inferior olivary nucleus, right? Okay, and our good friend medial lemniscus here, up here maybe two little dots, your medial longitudinal fasciculus. Okay, so this is going to be the approximate location of nucleus ambiguus in that ventrolateral territory of the medulla. So this is the one. So embryologically, you remember that it sinks deeper in the tegmentum. But if you are at this level, you're expecting it about here. So, and then for the ease of conceptualization, the makers of this illustration put the sensory components on the left side, motor components on the right side. So looking at the sensory ones, your viscerosensory ones are coming in, and they will be terminating in the nucleus of solitary tract, or nucleus tractus solitarius, right? And then they're going to have their primary afferent neurons in the nodose ganglion. And that's true for afferents from these places, pharynx, larynx, esophagus, all of these, but it's also true for baro and chemoreceptors, all of those afferents. They're going to be terminating here. The taste fibers, because there is a very small, but the kind of posterior area that is a taste recipient area in the epiglottis. It is innervated by vagus nerve, so that will go to a relatively more lateral portion of nucleus of the solitary tract. Okay, so-called gustatory nucleus. Some textbooks, and maybe Dr. Bob, when he lectures on, he's going to say, oh, here's gustatory nucleus for us. Don't be confused. Okay, it's still part of the NTS. I will never, ever ask you to point to gustatory nucleus, but get the idea of the taste recipient zone of nucleus of solitary tract. Now that ever so slight and variable somatic sensory territory of vagus nerve around the external auditory meatus, there is no separate somatic sensory system for this. It will join the system of trigeminal. So we'll come back to trigeminal for most of the somatic sensations. Okay, and then for the motor ones, I already mentioned dorsomotor nucleus of vagus. So via those peripheral ganglia, very closely embedded, usually in the walls of these organs. We'll go to the abdominal and thoracic viscera, and then from nucleus ambiguus, the pharynx and larynx muscles, including those constrictors, including laryngeal muscles. Okay, and this is a review of the vagus nerve. Again, it's something you would find in Siegel and Sapru. So our focus is on this nerve, these various types of components. We just see where they come from or where they go to. So they come from nucleus ambiguus, they come from dorsomotor nucleus of the vagus, and sensory information is going into nucleus of solitary tract. The nerve root is attached to post-alveolar sulcus. Excellent. So we just got those highlighted. So let's take a break at this point, and we'll pick it up with glossopharyngeal nerve when we come back.